Welcome. Good morning to everybody. Today I will discuss on a very important topic, that is massive transfusion and resuscitation. Massive bleeding in the operating room can be expected, as in a case of liver transplant or abdominal aortic aneurysm repair, or unexpected, as in the case of trauma, vascular injury or postpartum. Hemorrhage can cause decreased tissue perfusion, cellular injury, and death if not treated appropriately. Significant bleeding may result in the need for transfusion of large amounts of blood products. Definitions. Massive hemorrhage has been described as the loss of one's entire blood volume in a 24-hour period, or half of the entire blood volume in a 2-3 hour period. Massive transfusion is defined as transfusion to over 10 units of PRBC or blood products in 24 hours. Causes of massive hemorrhage requiring massive transfusions are variable. Any time of the day or night, one can be faced with potential for massive bleeding in most major centers and community hospitals. Management goals in the massive hemorrhage. The primary goal is maintenance of adequate perfusion and cellular function. Prevention of microvascular bleeding is a secondary goal. Lines and monitors. Standard ASA monitors plus invasive monitors are usually required. Central venous access. Large bore central lines are extremely beneficial for the volume replacement and can be used in conjunction with a rapid infusion device. Central venous pressure can be used as a guide for volume replacement. Ultrasound guidance should be used when placing the central venous lines whenever possible. While placement of central access can aid in the management, it can also draw attention and personal resources away from the treatment of the patient. That is one of the major drawbacks. Ensure that the patient is being adequately resuscitated while the line is being placed, or defer placement to focus on volume replacement. Intra-arterial blood pressure monitoring offers the ability for close monitoring of BP and frequent blood draws for laboratory analysis. Should be placed early in a hemorrhagic emergency, because placement may be difficult once significant peripheral vasoconstriction is present. Now, causes of massive hemorrhage. Cause of the hemorrhage, an example. Cause of the hemorrhage, suppose it is obstetric hemorrhage. Example, placenta accreta. Cause of the hemorrhage because of trauma. Example, motor vehicle accident, gunshot wound. Cause of the hemorrhage, surgical. Example, liver transplant, aortic surgery. Coagulopathy. Suppose it is the cause of massive hemorrhage. An example in the von Willebrand disease or factor deficiency. Radial artery is the most common cannulation site, but femoral is often used in emergent or difficult situations. Adequate IV access is essential in the bleeding patient. The flow of a fluid through a catheter is proportional to the fourth power of the radius. So large bore peripheral IV access allows for rapid transfusion. Recommended IV access includes 2 large bores, 14 to 16 IV cannula. Urine output. Monitoring the urine output is an effective indicator of the patient's intravascular volume status. Urine output less than 15 ml per kg per hour is indicative of severe volume depletion. Temperature monitoring. Monitoring of core temperature is essential in patients with hemorrhage. Hypothermia is extremely problematic in the massively bleeding patient because acidosis and coagulopathy are worsened by decreased temperature. Now come to airway management and maintenance. Massively bleeding patients may arrive in the OT or emergency department with an endotracheal tube in place. Severe blood loss significantly alters consciousness. The airway should be protected and managed by endotracheal intubation and ventilation. Maintenance of adequate perfusion. In order to assure the organ perfusion, intravascular volume must be maintained by large amounts of IV fluid, appropriate amounts of colloid, and potentially blood products. Blood products should be replaced with appropriate indications. Mobilization of resources. There is call for help of anesthesia technicians and additional anesthesia personnel. Mobilize the necessary equipment, notify blood bank and clinical laboratory, activate the massive transfusion protocol if applicable. Now we come to the massive transfusion protocol. Clear communication among all patients parties involved in caring for the massively bleeding patient is essential. A MTP that gives clear direction on laboratory data, blood product availability and transport, as well as equipment and personnel is extremely helpful. Instituting a MTP should be seriously considered in every institution where the potential to treat massive hemorrhage exists. let us stop it for today, today's lesson, and next time I will bring the remainder of this very interesting topic. Thank you.